We are absolutely thrilled to be here. Welcome all of you joining online. Those of you joining online who haven't met me, my name is Diane. I am postdoc here at Stanford. I'm one of the Innovation Health Equity Fellows, and my role is really thinking about how we bring the conversation around health equity and innovation together. Today, I'm very excited that the conversation on health equity and innovation is actually covering a topic that is not always at the forefront of innovation, despite its importance, and that is women's health and pediatric health. And so today we're going to be talking to three amazing women about their journey in pediatric and women's health innovation. And if you allow me to introduce them briefly. So Marta Arenas-Jal holds a PhD in pharmaceutical technology and an Executive MBA. She is passionate about healthcare research and innovation, and has several years' experience leading R&D projects within the pharmaceutical industry. She is currently a Maternal Health Innovation Fellow at Impact1. Welcome, Marta. Anuradha Dayal is a pediatrician, assistant professor of pediatrics, and alumnus of the Stanford Biodesign Faculty Fellowship. She has experience treating healthy and medically complex children in hospitals and outpatient clinics. She founded the BabySteps Orthopedics and has experience advising pediatric medical devices, digital health, and diagnostic health companies. Welcome. Juliana is an assistant director of Impact1, where she is developing a breath monitoring device for NICU patients, coaching innovators, and conducting policy research. She studied engineering before working in healthcare strategy consulting with global health innovation organizations. Welcome, Juliana. Thank you to the three of you for being here, for everyone in the audience for joining today, and for those of you online who are able to join. We really hope that this conversation centers women's health and pediatric health as an important area that has been largely overlooked. We know that there's been some exciting announcements in the US in terms of funding as we push towards a greater focus on these areas, but there's still so much work that needs to be done. We're hoping today to understand a little bit about these three incredible innovators and physicians' journeys, but importantly, the challenges and the resources in the space, so that any of you watching online or joining here in person today have a better sense of what are the real hard parts about doing innovation in this population, but also what are the resources, what are some of the lessons learned, so that we don't all have to start from scratch and we can harness the power of this community that's physically present and joining us online today. So without further ado, I'll hand over to the three of you.
Awesome, thanks everyone. So I'll start off by telling you a little bit about what Impact1 does. We have three different sets of things that we do. The first one is education. So we function somewhat as an accelerator where anyone working in pediatric or maternal health technology can come to us for coaching, guidance, connections, and in some cases financial support to help you take your next steps forward. It can be anyone from a doctor who says, I have an idea, what do I do next? And it could be a Series A or Series B company that's looking to pursue a different indication and get better access to patients, help patients have more access via reimbursement, or whatever their challenges may be at that point in time. And as far as translation goes, we have our own internal projects in development as well. So I'm working on a breath monitoring device in the neonatal ICU. Marta's working on a couple of different projects related to maternal health and perinatal tears, and there are other projects throughout our group as well. And then legislation. So we know that some of the current problems in pediatrics and maternal health aren't limited to things that we can currently do in the current ecosystem. And there might be a way to more broadly influence the ecosystem by getting engaged with national level players and recently international players. So with that layout, one other thing that I like to point out is we hear a lot about fundraising for children's hospitals, and we hear a lot about very expensive orphan drugs and ways that it seems like pediatrics is a field that is supported broadly. But something that's important to note, I think a lot of the Biodesign Fellows have learned about this year, is a little thing we call market size, right? Which is when it's very expensive and time consuming to develop this kind of technology. For some good reasons, and for some, what I might personally say are bad reasons. But at the end of the day, there are a lot of studies that have to be done to guarantee the safety and sometimes efficacy of a product you're trying to bring to patients, which is good. But when you have a limited population and you are capped at how much you can earn per patient, then that multiplication does not lead to a value that is often supported by traditional investors. And the reason we don't see that problem in drugs is because the pricing structure is actually flipped, right? So in drugs, the pharma company goes to the insurance and says, this is the price of our drug. And then there can be a discussion and negotiation to figure out what that final payment could be. But as we're seeing, that can end up being $1 million or $2 million a year right now per patient for that drug. In the device world, in the digital health world, in the services world, anything that's not a drug, you're often limited in your pricing structure by existing infrastructure. So there's a code, inpatient, outpatient, whatever it might be, that's associated with the payment, and your technology has to fall under that payment. And as a result, that math leads to a much lower market size than you might find in the drug world. So we're going to dive a little bit more in today, specifically into the area of pediatric and maternal health devices and digital health.
Okay. So as Juliana mentioned, I'm working on projects regarding women's health. Last year, our team during the Biodesign Fellowship started working on the prevention of perineal lacerations during vaginal delivery. So I've been working on that, and I think it's interesting to learn the definition of women's health in general, because sometimes there's a little bit of confusion, and also what are the main challenges that historically have been there and that we still face somehow, to understand how can we address them and innovate in this space. So when it comes to the definition of women's health, most people think it's about maternal, reproductive, or women-specific conditions, which is part of women's health, but this also includes conditions that affect disproportionately or differently women. So actually, if we look at the McKinsey report on closing the women's health gap, we see that considering the total global women's suffering, only 5% is due to women-specific conditions, 4% conditions that affect women differently, but 47% that affect women disproportionately. So we know, for example, that women are 7 times more likely to be, it's hidden, but to have a heart condition misdiagnosed or be discharged early during a heart attack. And this obviously correlates with an impact on mortality. And not only it's about diagnosis and early discharge, but also about seeking care. Because research has been male-oriented, and most of the data that we have is based on the symptomatology and presentation in male patients. So therefore, women seek less care, and even if they do, they have worse outcomes. So that's why I feel before trying to address that, it's important to understand what are the factors that have been limiting women's health innovation so that we can address and overcome that. Thank you. So first of all, I think, as I mentioned, one of the main issues has been the systemic lack of research. So women, particularly pregnant women or women of childbearing age, have been excluded of clinical trials. We also know that specific populations have also been excluded or misrepresented. So we know that, for example, African-American women are disproportionately affected by higher cardiovascular risks, but they are not fairly represented in trials. There's also lack of research in other subgroups, for example, we don't know much about transmission of sexual diseases woman to woman, and these affects we don't have screening guidelines, we don't have treatment guidelines. So there's a lot of research that it's lacking. And as innovators, we rely on this basic research to understand what is the problem, how can we address them, and if it's gonna work or not. So as an example, our team last year focused on ovarian cancer for a while. It was one of our top needs. It was also one of the top needs for one of the teams this year. And I think we all recognize that this has a huge patient impact, mortality, it's a huge unaddressed unmet need. But for some reason, and the reason was one of the main reasons was the lack of basic research, both teams ended up abandoning it. Because to translate basic research into innovation, we need basic research. Then there's a lot of stigma, and some complications have been accepted as normal. For example, I'm working on the prevention of perineal lacerations, and it's something that has been accepted as a normal complication of delivery and also the long-term consequences. And since it has been accepted, there are no treatments available. Therefore, the patients suffer in silence because they are embarrassed of their injuries, but they know that there's no treatment. So what's the point of, hey, I have urinary incontinence, which happens to about 40% of patients after delivery. So I think that's also another issue that makes that some of these issues are not, people are not fully aware of these issues. And also the fact that even if you jump through these hoops, which it's already difficult, then you face the reality that it's like VCs are mostly male dominated. So they may not fully understand like these conditions, the impact that they have, or they may even not have the empathy. So that's another challenge. And as Juliana was mentioning, in women's health, market size is one of the things that when you're working on this space, you get told like pretty often. And then you think about it and it's like, well, it's at least like half of the population. Why is this an issue? And also, if you look at other needs, like for example, no one questions like the market size or things like erectile dysfunction. And then like this affects the same percentage of population that needs regarding menopause. So I think there's a lot of bias and it's good to understand that it's there to be able to communicate in a way that helps bridge this gap. So enough of challenges. And now let's focus on the opportunities. So there's been a social change, unfortunately. Well, not unfortunately, fortunately. So now there's more awareness of these issues, more advocacy, and this has also led to increased research funds. So the Biden administration approved funding for women's health research and innovation. ARPA-H, which is also a government entity, launched a Sprint for Women's Health. They deployed about $100 million. So between 3 and 10 million per project to accelerate different initiatives in women's health. There's also funding from philanthropic sources like Gates. There are more and more impact funds working on that. And another thing that I feel it's really important is like, we not only have like the moral obligation to work in women's health, and that's personally why I'm passionate about this, but it's also a good financial opportunity. So as it was highlighted in a recent McKinsey and Silicon Valley Bank report, women's health is basically a blue ocean opportunity. So after decades of under research, under funding, and lack of awareness, it's a wide space. So that's why we can see that the interest like from VC firms has been increasing over the past years. And yeah, this is like one of the categories that it's growing faster, and it will continue to grow fast. And hopefully with more basic research, for example, as I was mentioning, ARPA-H launched the Sprint for Women's Health. One of the categories, for example, was on ovarian cancer. So things that as innovators we need to happen are happening. So we'll have more basic research available. We'll have more diversity in VCs, impact funds, more interest in women's health in general. And I feel it's a great time to be working on this field and innovating in this field because there have been a lot of challenges, but things are changing and there are plenty of opportunities and good financial returns as well.
I think another reason why things are changing now is because of the increase in gender diversity throughout all the roles that are needed in medtech. So as we have more women VCs, we have more women physicians engaging in entrepreneurship, more women CEOs, more women engineers. These problems can come to surface and the teams can be more willing to pursue the issues.
So I want to talk about the challenges and opportunities in pediatrics. I am a pediatrician. I've worked, with children in the hospital and outpatient for a very long time, and I was even surprised about this map. So what this map shows is the number of pediatric specialists and general pediatricians across the United States. So as you can see from this, there's a huge geographic difference on access to care. We are green here in San Francisco, but if you go out 1 to 2 hours away from San Francisco, you have kids who don't have specialists, you have kids who don't have children's hospitals, and pretty much like the middle of the country really has really poor access. Another thing that surprised me from the American Board of Pediatrics is that 47% of US counties don't even have a pediatrician at all. So how do our patients get access to care, right? But how do we also close the loop, right? Like if my patient lives 3 hours away and I'm booked out 6 months, how am I keeping track of how they're doing with their asthma? How am I keeping track on how they're doing with their short gut? How
if they live, 2 hours away from San Francisco, like it takes a parent 3 hours to drive one way to Stanford to be seen in the ER and drive back, right? Like we can do better with this. And that's where the innovation and as med device and digital health, like you can help us, right? Like we need to be able to close the loop with our patients. Let's do remote monitoring so we can see how our patients are doing outside. The three biggest reasons children are hospitalized are respiratory, cardiac, and chronic disease, right? Like, can we make new technology, new digital health technology to ensure that they can stay at home instead of having to come to the hospital all the time? And so what are we doing about this? So the other part of it is that now in the past 5 years, the FDA has also recognized that there is really not a lot of innovation in pediatrics, and they've given like $7.5 million to 4 or 5 sites across the United States and pediatric hospitals to help promote innovation. One of those sites is at Stanford UCSF, one's in Texas, one's in the Midwest, and one's in DC. And with this money, what we're doing is anyone who's interested in building a pediatric product, you can come to our meetings. You can tell us about what is a product, what is a problem that you see. We will tell you what is the unmet need. Is this the best approach to it? Like, actually, there's a whole nother diagnosis that would really benefit from this. So one way is that. Another thing the FDA is pairing with us is how do we get approval for medically regulated products for children faster? That's another important thing. And then we're also just talking to a lot of investors and family offices and impact investors on how to come up with different models to fund our innovation, right? So I think within pediatrics, a lot of times your money in the beginning is coming from grants and government funds, and then you spin out to VC. But once you're built really nicely and you have your clinical studies, you can get funding. Like Katnoa, they are doing an autism startup. They just raised $20 million, right? Like Hazel Health, they formed a new business model on providing care for kids in the school, right? Because there's no pediatricians around. Like, they've raised a lot of money. So there are a lot of opportunities coming up.
Another thing that this map makes me think of is I tend to think of innovation in 2 different camps. One is creating new solutions to entirely unmet needs that have never been solved. And the other is providing solutions to people who don't have access to existing solutions. And that can take shape, in entirely new forms and expand to, rural health, expand to other countries, just things. That's how I tend to think about innovation. So currently, this is a graph showing the number of US seed investments in medical technology. It's taken from PitchBook data over a 3-year period, and it showed that 19 out of over 300 companies that received seed investments for pediatric. Of those 19, 5 were addressing conditions that were solely pediatric, and 14 were devices that could serve both the adult and the pediatric market. Why is that? We talked about market size. There are a couple of other things that are challenging pediatrics. One is if you're doing any kind of long-term solution or implant, children grow. Their needs change, their anatomy changes, right? It's a difficult engineering problem. When you have a relatively rare disease and a smaller population, recruiting for clinical studies can be difficult. Right? And then there are extra regulatory and strategies in place to make sure that we are extra safe in our approaches with these kids, but again, comes with time and expense and all. So those are some of the challenges. And really a variety of funding approaches is needed to make these technologies get to where they need to go. So as Ani was saying, a lot of these technologies start with philanthropic initiatives and grants. The story of sick kids is a good one for grants and fundraising. Luckily, it's a bipartisan issue. People like kids, people like to make them healthy. So there's the other end of the spectrum, which is traditional venture capital. And then there's this middle area, which is kind of the impact investment. And we see more and more firms popping up here. There are reports on tremendous growth in the space of impact investing. But the idea is there really is good return on investment for what James Wall likes to call limo products, low in, medium out, right? So if you can only put $2 million into a product, a class 1, or early class, relatively simple class 2 device, right? Get it, such as Novonate, right? Get it to patients. Even if your exit is on the scale of 10, 20, 30 million, which is not what traditional VCs are going for, it's an incredible return, right? So when you have investment firms that are willing to look at those relatively smaller numbers, there's a lot of impact that can be achieved. Another really interesting example is CobiCure, which we have close ties to here at BioDesign and Impact1. They are a branch out from Deerfield, a finance firm in New York. And they are looking at this, return of capital kind of investing or grants, really grant giving, right? To provide a lot of these initial funds that are needed to get these products off the ground and de-risk them to a point where they could potentially get larger investment. Anu also mentioned the various FDA pediatric device consortium. So we here at Stanford, part of the UCSF Stanford PDC, are one of 5. Great place to get started. And they're really, that ecosystem ties into some of the advantages we see. So physician engagement. There are a lot of doctors out there who recognize that they don't have the tools to do what they need to do. A lot of surgeons, other types of physicians, use products off-label every single day, try to make adult devices work for kids. And therefore, as opposed to, perhaps adult orthopedic surgeons who are being approached every day by different reps trying to sell the newest knee implant, these physicians are rarely approached with new ideas, and you can get a lot of really active engagement that makes clinical studies go a lot more smoothly. There's consolidated users, right? So when you have the map that we were shown before, certainly has its patient access disadvantages, but also has its advantages for, again, finding the patients, finding the physicians that are working with the problems that you're trying to solve, right? So you can hit a lot of the market by working with a very few hospitals. Entrepreneur community. So these PDCs really touch the majority of pediatric companies that are up and running in the United States and create a very tight network where people are very open to helping each other. We recognize that we're all working towards very similar goals and are willing to make connections, give references to consultants and people that can help you and are very knowledgeable about this space, even let you use their equipment. I've heard entrepreneurs say, we bought this multi-million-dollar piece of laboratory equipment. We only use it X% of the time. And if any of the companies you work with ever want to use it, please let us know. Which is type of collaboration you don't always see in other spaces. So it's a huge advantage to working in this space. FDA pathway, so there's no filing fees if you're working with a pediatric specific device. The SHIP MD program is a new initiative. It doesn't really exist yet, but it's been in the works for about 3 years with very active discussions. And there's a design group going on right now to talk about what the system actually is. But the idea of it is there will be a system of hospitals that are coordinating collectively to help products move through from idea and conception to commercialization, to help them with their clinical studies, both for FDA authorization and to increase the likelihood of reimbursement. So when that program's up and running, it should be a solid pipeline for new technologies to move through. And then, like we mentioned, grant funding opportunities. It can be really good storytelling with pediatric technology. And with that, we'll turn it more conversational. I'll take any questions.
Before we dive into questions, I would love it if all of you could perhaps share 2 or 3 minutes just on a bit more detail about the projects you have worked on in the past or working on now specifically, perhaps one each, just so if there are any project-specific questions for you, that can also be included in the Q&A.
Absolutely.
Yeah, I'm happy to start. Most of you know that I'm working on perennial lacerations, as I mentioned. I think it's it has a huge impact on patients. It's a great unmet need. Sometimes
I'm going to stop you and ask for those joining online who may not know what that is. Will you just briefly explain?
During vaginal delivery, there's an immense stretch to the tissues surrounding the vaginal opening. And when the tissue cannot stretch enough and accommodate this increase in volume, then lacerations or tears can occur, either in the form of spontaneous lacerations or episiotomies, which is a surgical cut, to expand the tissue. So I've been working and innovating in ways to change the properties of the tissue we've explored different approaches from the medical device side, but also from the pharmaceutical side. Each one of these has different sets of challenges. On the device side, mainly regarding usability, workflow, and adherence. On the pharma side, it's a vulnerable population that usually has a high bar in terms of safety. So we've been really innovating to try to adjust the criteria and reduce the risk for that. And then during my fellowship within Impact1, I did clinical immersion in obstetrics. So I ended up not only working on this need, but also on the prevention of preterm labor. In that case, I was mainly focused on a pharma approach, but it was also challenging because, you needed to prove like long-term outcomes, and also some of the basic science was not fully understood. This happens a lot of in the pregnant population, where surprisingly some things regarding like delivery and childbirth have not been like really studied, and there's like a lot of information gaps, especially for complex conditions such as preeclampsia or like a hypertension during pregnancy, preterm labor, and other things like this. Like the mechanism of action is not really understood, and therefore like innovating is challenging. And also, as I mentioned, like from the regulatory perspective, or trying to like validate any of these assumptions also has like some risks, and therefore like the strategy can be challenging sometimes in this specific population, but it's also an area that needs a lot of innovation. So that's why we keep working on this.
One of my previous roles, I was the director of strategic innovation within hospital medicine. And what we did was we sourced and scouted clinical problems that physicians, nurses, were having within the hospital, to come and decide, like, is this a local problem? Is this a hospital problem? Or is this a national problem? If it's a national problem, is there something that we can help build in terms of a digital device, in terms of a medical device? How big is this need? And we would scout that and pitch it to different outside companies and outside like EMR companies to help co-create with us. I also started a pediatric orthopedic company called BabySteps Orthopedics. There are a lot of children who have limb deformities that are related to musculoskeletal. And it's so odd because, kids' bones aren't set yet. And so a lot of times what orthopedic surgeons do is that they cast a limb, let's say it's like your arm, and they like gently adjust where the arm like positioning or the foot positioning is over time with like a new cast over every week. And so what I saw what was happening is that I was in Washington, DC, and we had kids who like drove 4 hours one way just to see the orthopedic surgeon, just to get a cast, come back the next week and get it cut off and cut again. And so what I was talking with the orthopedic surgeon is like, is there a better way? Can we predict like what is the next positioning for this cast going to be? And we came up with BabySteps Orthopedics. We are collecting data and trying to figure out like an AI method of, can we figure out what the next cast could be? Could we print that? Could we send it to their home, almost like Invisalign, right? And just like have the parents do that at home. So that's, and then we secured 2 US patents for that as well.
Have amazing coworkers. Love to hear other stories. I started my project through clinical immersion in the neonatal ICU here. And there is a clear need to be able to detect early signs of necrotizing enterocolitis. So we call it NEC for short. The Latin there basically translates to dying gut tissue. And that's what's happening. It's a bacterial infection and inflammation in the intestines that results in necrosis or death of the gut tissue. And in 20% of the cases, death of the kid. So this is typically in premature babies. And we are building a breath monitoring device that's looking at the bacterial metabolites of this intestinal infection. So we ran a clinical study last year where we were able to show that we could pick up signals of these gases 1 to 2 days before current diagnosis. And we're now building a continuous monitor to have higher fidelity data and to be able to catch the disease at its earliest onset so it can be treated with antibiotics. On the flip side, because we don't know how to catch this disease right now, the fear of the disease really impacts the feeding paradigm and the care of every single kid in the NICU. So if you can have a really strong negative predictive value, which we believe we can, and say, no, we know you're worried, but it's okay, this kid does not have NEC, please continue treating them as you would otherwise and provide optimal nutrition, then you can really positively impact every kid.
Thanks, Juliana. Well, thank you so much, you three, for a wonderful presentation, but also sharing your projects. What really struck me is often when we speak about health equity, it's a term which may be vague to some people. And I love the fact that you brought in that it's local as well as global. It's not somewhere else for someone else, but we have huge challenges here in the US with maternal health, women's health, and pediatric health. Just to see that map was pretty compelling. But then the next layer of it's not just all women and children. We know that certain groups are even more, there's greater inequity in certain groups than others within that population. And of course, different challenges abroad as well, different and the same. So thank you so much for just sharing your perspective and for the resources. I hope that particularly for those of you in the room and working on maternal and pediatric innovation projects, that it's a good opportunity to connect in person. And for those of you joining online, that some of the resources shared can be of value. I am going to open up the room to questions. For those of you joining online, if you have a question, please type it in the chat. We do have someone monitoring the chat that can flag us if a question is raised. And feel free to ask anything about, if you are doing a pediatric or women's health project, or if you just want to learn more about the area in general. Rory, and please just share your name and where you're from briefly for those joining online.
My name is Rory Thompson, and from here in the Bay Area, and I'm one of the Biodesign Policy Fellows. So Juliana, when I love the distinction of the different types of innovation that you mentioned earlier, and it strikes me that latter category of access and how to make what is the most effective care kind of the standard of care seems like the huge opportunity given the variation and equity that we have. And just wondering if you have any thoughts about, is there a special approach that would work for those types of needs and problems? Or can we take kind of the biodesign need-based framework and apply that just like kind of a purely clinical?
Yeah, and I appreciate that. I think I'm in camp too, right? So the idea that you have the same problem, right? But you have different, as we refer to as biodesign need criteria, right? You can't make the same assumptions that you have every resource and every dollar that's available to you at an academic institution per se, right? Or at one of the 23 main children's hospitals. So I think that there's room to reimagine a solution as a whole, right? It's not about taking this exact catheter, that a interventional radiologist uses, right? And finding a way to make it cheaper so that it's more accessible, right? I think there are ways to completely reimagine the solution that you're providing in a way that you can, kind of downscale, right? Or use people of different training levels to produce similar results if they had different technologies at hand, right? Or if you could prevent people from getting to the point that they need that kind of advanced intervention, as you were saying, more remote monitoring and such. But, I'm trying to think of a way to tie that into the policy angle, as I know that's a lot of what you focus on. And I think there are some, it depends how, what exactly we mean by policy, but for example, just now, the AMA has put out new codes for remote patient monitoring to allow for further breakdown of time. It used to be you'd have to spend 20 to 30 minutes to get reimbursed via a code, and now they've broken it down all the way down to 10-minute increments. So if there's something that is highly efficient, can be done quickly and still make a big difference, the doctors can be incentivized to still do that work. And so I think looking at it from not just the innovation and practice level, but also how things get paid for, how things get funded, I think there's room for innovation there.
I think the other thing I would add is that the biggest payer for children is actually Medicaid, right? 50% of children survive on Medicaid, and that means 30 million children, right? And the hard thing when you are trying to roll out something to the Medicaid population is that every single state has different requirements and different ways that you can get into their system, right? It would be amazing if Medicaid could talk to all their state directors and come up with a plan that says, if you meet these 5 requirements, we all agree that it will be covered, and it'll be covered in our state. So I think that's another big counter, because, we always talk about small markets and total addressable market, but, 30 million children on Medicaid, all those children need developmental screening. All those children need screening for autism, right? All those children have problems with ear infections and asthma. There's 17 million children with asthma out there, right? Like there's a lot of children. We just need the way to create these innovations and distribute them through insurance companies and Medicaid.
Thank you, I'm Martin from Kenya in East Africa. So I want to move this thing from the US to other geographies because I know there are many people here from different geographies. And my question is, one, how the Impact1, how much advocacy or how much in the geographies to bring equity to this place, especially in child health, and also whether these funds that are there, whether they are available only for people, parents, or even out there. Thank you.
So what I would, I'll start off. I would say that one of the beauties of Impact1 is that it doesn't just focus on the United States, and it does focus on global. So we have global companies pitch to us what they're working on, and we are helping with those solutions. We recently did our Impact1 pitch competition like 2 days ago, and one of the winners was from India, right? And we have Gates Fellows, Bill and Melinda Gates. They fund a fellow every year to work internationally and use biodesign process in other countries, you know, to promote innovation. So I think that's a really unique part of it because technically the FDA PDCs, like the money can only go towards the United States companies, but we're very interested in doing work.
And I would say specifically our skill sets are biodesign need finding process, right? And US market in terms of go-to-market strategy and commercialization. So I think the ways, like in full honesty, the ways we can support global health companies are by making sure the need they're pursuing is a real need, right? And talking them through the process that you're now, you know, trained in, and talking through doing basic coaching on need spec, doing basic coaching on market landscape, making sure, not that we have the full understanding of the system, but making sure we're guiding, we're leading, providing guidance on how you can be analyzing your own market and need. And then for companies that are looking for funding globally, a lot of international companies want to be able to pitch the US market, right, to global investors to understand that global TAM and market size, right? And so helping understand what US market entry could look like. And then yes, some of our seed funding can go to international companies as well. So I would say those are the big main categories of assistance.
I would add that, yeah, like for any project like that is interested in pitching to us, like on our website, there's a link. So you just need like to fill in a form and then you'll get to pitch your project or company like to experts that are like, yeah, on the clinical side, engineering side, market access. So we can offer like all these resources. We do it for free. We're always happy to chat with any innovator, regardless of their stage. And so yeah, we're like really passionate about that. And also like, when it comes to internal projects, we not only have like projects that are mainly based outside of the US, but even the ones who are in the US, I think we all try to take into consideration the impact of these needs in other geographies. So for example, I speak to my case, like when it comes to perineal lacerations during childbirth, they have like long-term consequences that we know that here are a huge problem, but there are other places and especially low resource settings where this is even a bigger issue. So when designing the solution and also, yeah, we take into consideration aspects such as scalability, cost, and also we are also exploring like different business models to capitalize like and have like a higher price point, for example, in the US, so that then we can like fund and deploy in other geographies. But yes, Juliana mentioned like since the projects that are US based, like we mainly did clinical immersion in the US and have all the contacts here. I feel like most of the criteria has been tailored to the US, and then we would have to do another immersion or think like about specific characteristics, but it's something that we all have in mind and we try to help as much as we can.
Are there any questions online yet?
Yeah, hi, my name is Claire. I work with the World Health Organization. I just I'm actually curious if we can talk a bit more on this piece, because I think we're seeing there's so much, like it takes so much time for products to then scale up to other markets. Are there ways that innovators can accelerate this by already thinking about different criteria or ways that you're helping to make that happen quicker? So a product that has been designed for US market, how quickly can then it be deployed to other markets where they might need some adjustments?
It's something we like to bring into our coaching early. A lot of the companies that pitch to us at what we call our innovators forums, we have them twice a month. You know, we talk about what, you know, reusable versus disposable components, right? And I think we're all pretty familiar with examples of companies that have had global health promise and have failed to deliver on that. And there are learnings from why that happened. Certain aspects of their design for manufacturability that occurred in the US, you know, wasn't cost effective or you know, able to be cleaned in a way that would make it available globally, right? So I think bringing those materials questions, those design questions in the very beginning can just get the wheels turning, right? And try to incorporate it as early as possible. Other thoughts on that?
Yeah, I think it's mainly in the design implementation too. It's true that like when you do like immersion specifically in the US, you learn like the needs that are here that may not be able to translate in other places. So that's why I feel it's also important to have like field experience or immersion like in the other geographies to really revalidate the need, the criteria, and things I feel like cost or scalability and access are like really important aspects. And I feel in Impact1 it's something that we always have in mind and try to apply to our own projects. And then as we mentioned, we really help projects where they're like in the different settings and geographies and they are like more well connected with the ecosystem. We help them accelerate their innovations and make these things possible.
Yeah, it's a hard problem. People have limited resources at these early stages, right? One market at a time is generally the approach, but at the same time, just thinking as early ahead as you can to plan for as much as you can.
We have a question online, and will you read it out for us?
Yes, of course. Someone asked the question, what are some of the unique challenges in innovating for the pediatric population? For example, you mentioned that 50% of children are on Medicare, and that has reimbursement challenges.
Yeah, absolutely. You know, it's a tough problem. So I think the beauty of this past 5 years is that as physicians, as pediatric hospitals, the community, we're trying to address all these problems one by one, right? Like, so let's think about reimbursement codes. Let's think about how insurance pays for it. But also what we have to think about is what is the return on investment for a VC is different from a hospital, right? Like as a children's hospital, there's only 200, maybe 220 across the nation. And what they need is to make sure that kids aren't being readmitted, that there are not complications, that you're reducing their length of stay. And those things, you know, are actually very, very important for a value committee to consider. So when you're coming up with a pediatric innovation or a device or anything like that, like getting a hold of those numbers is can really help you go further in terms of figuring out, like maybe your market is small, but this is what hospitals need, right? Like if I don't have to readmit a kid for asthma and like take up 2 bed days, and then there's like a cardiac kid waiting for a bed, like that's huge, right? So there are other ways to think about it.
Yeah, but I would say just to list off a few of the main challenges, kind of like you mentioned before, is kids grow. You have to take that into account for engineering. When you have rare diseases, it can be more difficult to power a study to the point of proving efficacy, and to the number of sites you might need to get a certain number of kids enrolled can be challenging. You know, and again, market size, but not for all conditions, but you know, for so many, it can be challenging. There's another point that I'll come back to that I forgot.
More regulation.
Yeah, that's okay. Thank you.
But to Anu's point, I feel like some of these challenges regarding reimbursement also apply to maternal health specifically, because there's also a global maternity bundle. So the hospitals get paid like the same amount like per episode of care regardless of what they do. So I feel like having information on like the value analysis and cost effectiveness analysis can also help drive some of these decisions, especially if like the costs that you're saving are like in the short term. Sometimes even if the impact on patients is huge and costs long term are also huge, in the US particularly because of the specific incentives of the healthcare system, maybe challenging to convince some of the stakeholders of the savings long term. In other geographies may actually be the opposite. Like, so for example, I'm from Spain, so in Europe or in healthcare systems that are like more integrated, any cost that you can save short or long term will of course have a benefit and be recognized. But in the US, like sometimes some incentives may not be as aligned. And then like having information like this, I think it's really helpful, especially for needs where the reimbursement may seem more challenging.
Yeah, thank you, Marta. That's the point I forgot to bring up from something you said, is that I personally have started to seriously question whether, pediatric companies should be starting in the US. I think it's often I think the US market is often seen as very desirable by countries all around the world because we pay a lot for our healthcare. But when you look at long-term value, the value you are providing, the argument is much, much stronger in single payer systems when you are creating you are preventing lifelong complications, and you're not like in the US adding up the events one by one throughout the lifetime. Even as we start to have more value-based care, it still tends to be within a minimal time frame compared to a lifetime. So maybe yes, the ASP is going to be higher in the US, but big picture in terms of widespread adoption and patient impact, maybe we really need to be looking elsewhere.
Juliana, we have another question online, so I'm going to go online. Oh, okay.
Hi, I'm Li Chen, a urologist in Taiwan and focus on the pediatric urology and female urology. So the situation you mentioned that during the pediatric surgery, some surgeon will use the adult technique to address the pediatric population. It also happened in my surgery, and even in my hospital, it's already university hospital in Taiwan. But I want to mention that the project we have the funding. We want to have the funding for our project during the pitch. It's very difficult. It's very challenging because of the market size. The pediatric population in Taiwan is very, very small. I mean, compared to adult population. So I'm curious about the Impact1. Is this company welcome the ideas from the Taiwan or from other countries, and can we contribute something to that?
100%. I highly encourage anyone here in person, if you have any idea or project or company related to pediatric innovation, you can go to the Impact1 website, which is on the Biodesign website, and you can sign up to pitch to our team, which is really just an intake. We hear your problem, your solution, and we identify ways that we can help. To your specific point here about having innovation that could work in Taiwan, one of the first things we could do is teach you more about the US treatment paradigm, right? And potentially connect you to surgeons in other countries that could teach you about their paradigms, right? And we can understand how this problem translates and therefore how the solution could or maybe could not translate, at which point you could start to think about, yes, global market and funding from that degree.
And one of the co-directors of Impact1 is a pediatric urologist, so I'd love to hear it. That's for your work on as well. Thank you.
Quick question online. Someone wants to know, can you please share your personal definitions of health equity?
I think to me, it goes back to those two categories of innovation, and what I define as the second one is making sure that everybody has access to every solution that our scientific knowledge allows us to have today. And those solutions are going to take different forms. But yeah, that's what it means to me.
Yeah, I think for me, it means access. It means, different socioeconomic populations have access to different care. Certain diseases are in different socioeconomic, populations as well. So I think there's actually lots of different, and then also just equity and that realm as well.
Yeah, I think we're like expanding the definition, so I just like add to them that I feel like taking it into consideration within all the R&D continuum, and not only like once there's a solution and it's applied, but also on the research before, on the clinical trials, on the funding, on the diversity of the teams who are doing that, because we know this correlates with better outcomes for everyone. So I think it's probably
all the way through.
Yeah.
Again, I realized I said, with science available to us today, but science available to us today is also insufficient, right? And there are inequities in that. We need to be filling in those gaps.
Diversity of data, right?
Yeah.
So, I mean, that's really
And for those joining online who may not be familiar with Stanford Biodesign and our definition of health equity as a whole for the center, as you know, health equity is a vast topic and there's many different components, but we specifically focus on health equity when it comes to innovations to make sure our innovations are culturally appropriate, contextually specific, affordable, accessible, environmentally and financially sustainable, and really go out to meet unmet needs, whether that's locally or globally. And so that's how we think about it as a center for any of you online who may be interested in that. Any other questions? Go ahead.
It's current biodesign fellow. Before you brought up the big three hitters for pediatrics around like cardiology, respiratory, and chronic illness, could you talk to trends you see now as far as like child development, whether it's mental or physical? Like, is there support there?
Yeah, so, mental health is huge now. And there have been a lot of really great companies coming up with mental health solutions. There's Spend Health, that's doing really well. Autism, Cognoa just formed a company and they are able to more early diagnose autism. We know that if you have a mental illness when, whether it's bipolar, whether it's depression, whether it's anxiety, as a teenager, it's gonna follow through, as an adult. So there are a lot of companies that are focusing on like the preteen to like early adulthood and how that adjusts. Let's see what else is out there.
I would say across the board, there are more and more companies popping up, none that have quite made it to the finish line yet, none that have really, turned to positive revenue and shown widespread patient impact. But they're
I think it's coming though. No, I think it's coming. Like among the clinician community, we all use Spend Health, right? We all use these mental health virtual therapies for our kids, and we're waiting for the other ones to, turn the profit and get insurance coverage so we can do stuff. I think as a pediatric community, we're very, very collaborative and we talk a lot. So if something works, we spread the word. We want that adoption. So if you make a great product and you involve clinicians from the beginning, you won't have a problem spreading that word. And we are right now helping with the reimbursement, with the regulatory, so that by the time you're ready, hopefully it'll be pushed out.
I'm intrigued by the map that shows the distribution of health access for these kids.
Yeah.
Is there a reason for it being skewed that we know of? That's one. And then are the health outcomes for those in the disadvantaged areas evidently different from the ones with access?
Yeah. So your first question is why, right? Why are these big cities? So there's actually not a lot of people going to pediatrics in general, and there's even fewer people going to pediatric subspecialties. And especially when you're in a pediatric subspecialty, you need to be in an environment and in a hospital that does all kids, right? Because you can't be a pediatric cardiac surgeon in an adult hospital. Because you need all different tools. You need nurses who are trained in a different way. You need anesthesia machines that are different, right? And so, that leads to like these pockets and like at these centers. And and the kids in the middle of the country, absolutely, they're going to have disparities. The time that they can get diagnosed for autism is like the average age is 7, right? I mean, and there's not a lot of developmental pediatricians out there. There are wait lists for 2 years just to get diagnosed with autism, right? So absolutely, it lends to health inequity. The other thing that's interesting is that there are 220 freestanding children's hospitals, but in adult hospitals, they're closing down all their pediatric beds, right? So if you go to an adult hospital and you're a kid, they, Howard County Memorial, it's like 3 hours north of here. Every day they send at least 4 to 5 kids, one to UC-South, one to Oakland, one to Stanford, and one to somewhere else. So they don't even have a bed available, right? So that's a big problem.
There's also an element of even people who grew up in rural communities, by the time you're away for 4 years of college, 4 years of medical school, 3 years of your pediatrics residency, and then however long your fellowship is, you've established your life elsewhere and you haven't lived in that rural community for a very long time, and your career opportunities, these centers that have all the different specialists don't really exist there. And I think to go through all that and then to go back to being, the pediatrician in the neighborhood you grew up in, just becomes less attractive to people, fortunately.
And the second part of your question around outcomes, was there a specific area you were curious about outcomes in?
Yeah, just generally, because the way I view it with my own lens is that if you had a hospital it would make a difference, So I know that even the areas which are red, all have hospitals. So the way I look at access is a bit more extreme compared to the US. So I just wanted to know if the fact that they had hospitals actually made a difference on these kids, or they were clearly disadvantaged in terms of health compared to where they had pediatricians.
There's outcomes and such. It probably depends on the exact hospital and facility.
Got it.
I mean, but 17 million kids don't live close to children's hospital, right? So that's gonna affect your asthma, that's gonna affect your autism, that's gonna affect, if you have a cardiac heart disease and now you're in heart failure, right? Like, so absolutely, but I don't have that.
And with children's health, I think we should definitely recenter social determinants of health in the conversation, because yes, treatments and cure is important where possible, but a lot of the red we're seeing is also just because of differences in access to things like education, good nutrition, that we know influence health, that for a long time our strictly biomedical model has ignored. And that's why we're so passionate about bringing social determinants of health into this conversation as a centre, because we recognise that health outcomes start long before the illness or disease manifest. We have time for one last question before we wrap up. Is there any more online, any more in person?
Yeah, just thinking through, I'm very impressed with what you're coming up with, but I keep thinking, and from the way it is discussed even in the US, then it actually manifests how as it is when you go to low medium income countries. So looking at your strategies in terms of like the seed investment, even after pitching, I'm trying to look for in terms of sustainability. What kind of strategies are you having considering those areas such that even when these pick up, considering how big the challenge is, these companies will be able to sustain themselves into the future after, of course, the withdrawal of the support, if it's from philanthropy, grants or such, to move forward? What kind of strategy are you looking at so that that is able to be realized in those settings?
Thank you. Well, at least in my case, like for example, when I was screening different types of solutions, that was one of the things that I considered when comparing them, like which solution could be easily scaled on in other places, and some requirements, like for example, in my case, if I'm thinking about the pharma solution, I know that in terms of manufacturing costs and scalability may be better than a device probably. I know that if it's not refrigerated, it doesn't need to be refrigerated. It's better in terms of like access and like the distribution chain. So I think, when like thinking about specific aspects of the solution criteria and also screening solutions, it's something that at least, we take into consideration. And then I guess also depends on what's the main model, like for projects who have philanthropic or grant funding, and it may be easier to target first like populations with access issues. For projects that need to raise VC funds, it may be more challenging to focus first on these populations. So I think the hope is like first to make the case for the business case, and then once that has been established, being able to expand it and ensure that there's access. But
I think there's also just questions. I think we define sustainable business more than, looking at market size, right? So based on the cost of development, the cost of goods of the device you make, and what you believe you could be able to sell it for in whatever market you're going after, is there a sustainable business? Does that math make sense? And I think just looking at it from that lens can help you from the design phase, right? Figure out what your cogs need to be to pursue that solution, right? And I think the math is going to look a little different for each region. But generally, there are some groups that will always have to be philanthropic if you really want to pursue an idea that just doesn't have that business model, right? There are some groups that can survive off impact investing and then just kick them off to the point far enough that they can then have their sustainable business model running. And then there are those that are farther on the VC end that they're going to want continuous revenue, right? And you have the higher ups to really return capital to. right? And I think there's just different companies and models along that continuum that are going to be region and problem specific.
All of you joining online, I know we have some folks that may be clinicians or may not be familiar necessarily with the biodesign method yet. We have a full resource guide available online if you'd like to learn more about the principles that were spoken about today. And if any of you in the room or online would like to get in touch with Impact1, as Marta mentioned, you can go to the Impact1 website and sign up to pitch your innovation. You can also sign up to become part of their community through newsletters. They have an active presence on LinkedIn if you'd like to learn more. And we encourage this conversation to continue even after the session because it is such an important part when we think about health equity and innovation. And before we wrap up today, I'd just like to thank Anuradha Dayal for helping put this webinar together. For just sharing your time and expertise on this important topic. And for everyone who's able to attend in person and online, I'd like to just close with a thought that Margaret Mead once said, never doubt that a small group of thoughtful, committed citizens can change the world because it is the only thing that ever has. And whilst we acknowledge that it is a small and thoughtful group of committed citizens like ourselves who are interested in maternal women's health and pediatric innovation, we absolutely can and will change the world if we work together. So thank you for joining today. And there's snacks for those of you in person.